Hello, and welcome to this virtual case session 9, Complex PCI. I'm Dr. Francisco Jose Ayala from the University of Chile Clinical Hospital, and I'm joined today by a distinguished faculty members. Welcome, everybody. We got a great session today where we are going to be looking for important topics for us in interventional space with real-life challenging cases in our daily practice that will be shown by the presenters. Again, welcome everybody, and we hope you will enjoy this academic session. Without further delay, I introduce my co-chair, Dr. Seung-Ho from Keimyung University, Dongsan Medical Center, Korea, and the panelist, Ryoji Koshida from Toyoyashi Heart Center, Japan, Kyusup Lee from the Catholic University of Korea and Daejeon St. Mary Hospital, Korea, Zhehao Piao from the second affiliated hospital of Wenzhou Medical University, China. Dr. Seung-Ho will introduce each lecture before the presentations. We have approximately 1 hour for the online session, and please keep the time allocated for the presentations. Dr. Seung-Ho, please start with the presentations.
Okay, so thank you, Dr. Riquelme. And it is my great pleasure to introduce each presenter and titles. So we have the 6 presenter. I'd like to introduce the first presenter, Dr. Takuma from Japan. His title is How Do You Manage It? Dr. Takuma, please.
I'm from the Nagoya Exaka Hospital. I have no disclosure. And the case was 55 years old with RC CTO. The CTO was very long, the proximal to the distal PTA. And she showed that very good collateral from the septal branch and also AC channel. So I started the primary regular approach from the first septal up with a crosshair. And, but the septal channel from the UB3 couldn't pass the retrogradely. So I changed to the AC channel. So, but kind of a chip injured the AC channel with perforation like this. But the SO03 could pass to the distal PTA. However, it was difficult to the proximal PTA. So I performed the balloon screening method from the septal branch like this. And after the trapping the chip of the carrier and trapping the cover, and penetration was started from the retrograde with the glass. So after that, antegrade knuckle wire and retrograde knuckle wire technique was performed, and the guide extension reverse cut was performed like this. However, can you show my eyebrows? Eyebrows show that some problem, big problem. So this is a distal PD branch. So, and I show you the more proximal side of the CTO. So inside the CTO, the very huge hematoma was observed. And furthermore, the a part of the CTO segment, the guide wire exists outside vessel. You can see like this. So the vessel structure was observed in the 1 o'clock. So the guide wire exists outside the vessel. So in this current situation, show that this slide. So the retrograde wire shortcut the distal PDPA branch bifurcation. Furthermore, the inside CTO, the vessel guide wire exists outside the vessel. So it means if the stent was implanted with this guide wire position, it's have a risk of the perforation and losing the 4 distal PTA. So I performed the retrograde rewiring with antegrade IVAS guiding. So IVAS guided retrograde wire was performed, and once more the reverse cut was performed. So it's a schema of this case. So antegrade IVAS guided retrograde rewiring was succeeded to externalize second attempt. So this is IVAS for the second attempt. So you can see the second guide wire was observed in the 7 o'clock. So the second guide wire track inside the vessel. Like this. And after that, 5 DES was stented into the CTO. So finalized was a good outcome like this. So discussion point 1 is importance of the retrograde channel selection for the retrograde wiring. So coaxiality is very important for the penetration. So next is the utility of the balloon screen or anchoring or trapping or stabilizing retrograde system, like this. And third is IVAS guiding retrograde wiring. So at this situation, the anterograde, the huge dissection was occurred. However, the distal part of the CTO have less trauma, so we can get more controllability for the guide wire from the retrograde. So the retrograde rewiring with antegrade IVAS guidance is useful by that complication. Thank you.
Thank you, Dr. Takuma. Thank you for your good case. Is there any question and comment for this case? The first, I would like to ask Dr. Takuma.
Yeah.
Thank you for your nice case and successful result. So in this case, the main point is how you can recanalize the second wire under the antegrade IVAS guidance.
Yeah, it's a very
point. Yeah.
It's the same as antegrade IVAS guidance. Yeah, it's actually you can perform the IVAS guided wiring from the antegrade, but it's the same with retrograde. So the important is understand the IVAS image with co-registration with angiography. Okay. So it's a very key point for the IVAS guiding wiring.
In this case, how you can decide the angiographic, the aerial or RIO or how?
Aerial caudal and the aerial cranial.
And then the second guide wire you can manage it.
Yeah.
That direction, right? Yeah. That's a very important point.
Dr. Takuma,
yep.
Could you please explain us why did you choose first the retrograde approach and then you went by the antegrade approach? Is because the images of the cusp, the long of this lesion, whatever. Please explain us your technique.
Yeah, but at first the septal is very matured, so the risk of the retrograde is very low. So I set up the primary retrograde approach because of the very long CTO and the ambiguous CTO course, vessel course. So, however, I cannot perform the retrograde wiring with the intermediate guide wire like Gladius or UV3. So After that, I changed to the antegrade approach. However, the antegrade approach was all failed with a very severe calcification. So I switched to the retrograde once more with AC channel.
Hi, Dr. Takuma.
Yeah.
Thank you for your interesting case and successful result. I think before stent implantation, I was guided. Decision making was very excellent and important. If you just PC stent implantation, just not seen, I was finding. It makes the very disaster. Yeah.
Yeah. Very nightmare.
Yeah. So yeah, I learned your case from your case. Thank you.
Okay, Dr. Takuma.
Yeah.
So I know the Dr.
Yeah.
Takuma Tsuda, so he's very enthusiastic and maniac for intervention. So I'd like to check your selection of the antegrade guide wire for knuckling.
Yeah, antegrade knuckling wire is used by the Gradius MG. So, however, at this time, this guide wire is not approved in the Japan with coronary.
So maybe the Gradius MG is has a strong support.
Yeah.
Support. So sometimes maybe I don't use it.
Yeah.
Yeah, maybe the sort of maybe antegrade guide where you go out the vessel, right?
Maybe the retrograde guide wire go outside.
Okay.
So
add one option from the retrograde guide wire. So using the septal. So I'd like to try to cross the septal channel, dual lumen microcasside.
Yeah.
Yes, and one guide wire go into.
Yeah. Actually, I didn't show this slide. So, but I tried actually the septal branch with Sasuke dual lumen catheter or the balloon screen technique. However, I didn't show this slide, but I cannot penetrate the CT or retrogradely. Neither.
Thank you. And yes, and one more. So the septal channel is very mature.
Yeah.
Yes,
very. So the exercise is leaving the 2-0.
Yes. So the sometimes try to the retrograde system, two systems. So one system for the PO and one system and for the CTO. So the two microcasside and guide wire within the PD artery. So maybe they extended the segment of, so bifurcation curve.
Okay.
Thank you.
Thank you.
Okay, so is there more questions? Dr. Takuma, I had the last question. So why you use the balloon screening techniques?
Yeah.
So what size of the balloon you use?
2-0.
Oh, 2-0. Usually you use 2-0?
2-0. But no. But it depends on the vessel size of the PDPL size. Yeah. So it's this PDPL size is very large. So, however, but the larger one is very traumatic. So I hesitate the 2.5. So I hesitate.
And also using that technique. So which guide wire is the preferred to the balloon protection technique? The retrograde guide wire.
Maybe anyone is okay, but I use Sion Blue in this case. So, but the AC channel for AC channel, I choose SO03.
Okay, thank you. So, is there any questions?
Yes. No. Thank you very much, Dr. Takuma, for this educational case. I think we have to move forward to look at the next case because of the time.
Yeah, thank you.
Dr. Seung-Ho?
Yes, I'd like to introduce the second presenter, Dr. Dmitriev from the Russia. His case is the embolization of the arteries of the lower jaw and the massive bleeding from the aneurysmal bone cyst. Dr. Dmitriev, please.
My name is Dmitriev Igor, and it's a great honor for me to speak here. Let me introduce you the report embolization of the artery of the lower jaw with massive bleeding from the aneurysmal bone cyst. Before starting, I would like to inform you we don't have a conflict interest. Aneurysmal bone cysts are non-cancerous tumor-like vascular formation consisting of the filled blood ducts. Although they can be found in any bone, they are most often found in the thick lower leg and vertebra. Aneurysmal bone cysts of the lower jaw is extremely rare pathology. By far, the majority of aneurysmal bone cysts are present in the metaphysis of the long bones, about 6-7%. They also occur in the spine, 15%. Particularly the posterior elements, pelvis 9%, and less frequently they can appear in the craniofacial bone and epiphysis. They are relatively rare in the jaw, accounting for about 1.9% of all ABCs of skeletons and about 1.5% of all non-odontogenic cysts of the jaw. Causes. Vascular malformation is thought to be the cause of aneurysmal bone cysts, but the ultimately cause is unknown. The current thinking is that the vascular malformation lead to increased pressure and expansion in the bone itself, causing erosion and resorption of the involved bone. Most primary aneurysmal bone have a chromosome translocation, which activates oncogen, which stops osteoblastic mutation. Treatment, curettage, and block excision are the methods of choice. Other modalities include radiation, cryotherapy, percutaneous intralesional injection, calcitonin therapy, and embolization. In that work, we present the case of embolization of arteries feeding the aneurysmal bone cysts of the lower jaw. The girl of 8 years old turned to the dentist with bleeding from the gum in the area of 4.6 tooth. This tooth was removed by the dentist. After that, started profuse non-stop bleeding from the hole of the extracted tooth. The girl was hospitalized in the Central Hospital, where was received an embolization of arteria alveolaris inferior on the right and the tamponade of the hole of the extracted tooth. After that, the bleeding was stopped. Then the girl is transferred to Children's Hospital for further examination and treatment. Upon receipt, 2 days later, the patient bleeds again and surgical treatment is urgently performed for the child. Revision of the hole of the tooth and wax sponge is applied. Hemoglobin level is 18 gram per liter. The bleeding doesn't stop and the patient is transferred to the Republican Center for embolization of blood vessels supplying the cyst. Diagnostic. According to computer tomography of the facial skull, expensive multiple osteolytic damage to the lower jaw on the right and multiple fluid in the cystic area. According to angiography data, we found highly vascularized formation, blood supply from the right arteria facialis, and stagnation of contrast. Treatment was performed transfemoral access with local anesthesia with GR6 French catheter using the Terumo Progriat microcatheter and embolization material PVA 100 micron. Perform selective embolization of arteria facialis on the right. Because the right arterial bull of the lower jaw always anastomoses well with the left side, it was decided to perform selective angiography of the external carotid artery on the left, where found hypervascular formation on the lower jaw on the right was revealed, abundantly feeding through a network of collaterals from the left arteria alveolaris inferior and left arteria facialis. It was decided to perform selective embolization on the left side. In this picture, we see the network of collateral from the left to right. Successive selective embolization of these arteries with material PVAs to 100 micron. Results. Bleeding from the gum stopped, and during the observation in our center for 1 day didn't review. Bleeding from an aneurysmal bone cyst after embolization was not observed, and during extended curettage, blood loss was only 10 milliliters. According to biopsy, the formation was an aneurysmal bone cyst. After surgery, pain was not observed, bleeding from the gun was not noted, antibacterial and symptomatic therapy were prescribed. The girl safety discharged and is now in completely health. The postoperative result was good aesthetically and functionally. The operative site was healed with normal bone structure, and no additional treatments such as surgical reconstruction or bone graft was necessary, which was beneficial for young child. Subsequent observation consisted of clinical and radiological studies within 1, 6, and 12 months after the procedure. No relapse was observed. Conclusion. Early diagnosis of aneurysmal bone cyst is very important, and appropriate treatment should be given, taking into account factors such as age, surgical complication, and the possibility of relapse. To identify aneurysmal bone cysts, the computer tomography method is the best choice. Many attribute high rates of relapse to incomplete removal during surgery. A problem that can lead to incomplete removal is massive bleeding. Preoperative embolization of the arteries supplying the cyst flow for safe curettage in the relativity bloodless area. This ensures complete removal of the area, eliminating the likelihood of relapse. And embolization is an effective procedure in the treatment of aneurysmal bone cyst and may be included in the main treatment method. Thank you for your attention.
Thank you, Dr. Dmitriev, for this educated case and infrequent for our practice. And this shows that interventional treatment can be applied for many situations, and this is a special situation. I want to ask you, why did you choose the femoral route instead of using some of the radial route or whatever we try to use nowadays, not to be so invasive?
This case was an emergency, and we perform femoral dostup very frequently in Russia.
Okay. And do you recommend, as I saw in your conclusions, that many of these cases have been to evaluate before and maybe do the embolization before the treatment of the curettage? That is your proposal?
Yes, I'm recommended using embolization before curettage because it's blood loss after curettage very less when without embolization. I think.
Okay, thank you so much for your presentation. Please, Dr. Seung-Ho.
Okay, so I'd like to introduce the third speaker, Dr. Murthy. His title is the Post-MI Ventricular Septal Rupture with Heart Failure Treated Successful and Transcatheter Device Closure. Dr. Murthy, please.
I'm Dr. Murthy, and I will be presenting a rare case of post-myocardial infarction ventricular septal rupture with heart failure, which we treated successfully with transcatheter device closure. I have no conflicts of interest. Our patient, a 16-year-old gentleman, a tobacco chewer, presented with anginal chest pain of 8 hours duration. He was averagely built and nourished. Vitals were stable, systems unremarkable. ECG showed ST elevation in inferior leads, ST elevation in lead 3 more than lead 2. Echocardiography showed regional wall motion abnormality in inferior wall in RCA territory. He had an ejection fraction of 50%. He was immediately taken up for primary angioplasty since he was within the window period. Angiography showed mid-segment LAD significant lesion in the LCX, and in the culprit artery RCA from proximal to mid-segment, there was a tubular lesion 90% maximum. The culprit lesion in the RCA was stented with good result. Subsequently, in a staged PCI, angioplasty and stenting to LAD was done with a drug-eluting stent with good result. So also, angioplasty and stenting to LCX was done with good result. Subsequent recovery was uneventful. His ejection fraction improved to 60%. There was no regional wall motion abnormality. He was discharged on standard dual antiplatelet drugs, statin, beta blocker, and ACE inhibitor. He remained asymptomatic for next 2.5 months. However, later, after 2.5 months, he presented with breathlessness, undue fatigue, and swelling of both lower limbs of 2 days duration. Symptoms were sudden in onset. At this time, on examination, he had tachycardia, tachypnea, hypoxemia, bilateral pedal edema, JVP was raised, he had bibasal crackles, tender hepatomegaly, and pansystolic murmur in left sternal edge. Based on these clinical findings, a diagnosis of congestive cardiac failure with a possibility of post-MI ventricular septal rupture was made. Echocardiography showed normal LV function, RA and RV were dilated. Apical 4-chamber view showed a large ventricular septal defect with left to right shunt. It was located towards the apex. It was apically located, and the maximum diameter was 14 millimeter. He had moderate PAH. So a diagnosis of post-MI ventricular septal rupture with left to right shunt with congestive cardiac failure and moderate PAH was made in a background of coronary artery disease, triple vessel disease, post-PCI status. He was stabilized with anti-heart failure therapy. He was aggressively managed with diuretics, ACE inhibitors, vasopressors. IABP was on standby. He was discussed with the heart team and was decided to electively close the ventricular septal rupture after 4 weeks. After 4 weeks, he was re-evaluated and chosen for transcatheter closure. Planning of transcatheter closure was done meticulously, right from the access to hardware to AV loop and to the device to be used. We chose right femoral artery and right internal jugular vein for arteriovenous loop because if you come from the femoral vein, right femoral vein, you will have to negotiate 2 acute bends, one at the tricuspid valve level and the other at the apical ventricular septal rupture level. But if you come from the right internal jugular vein, you will have to negotiate only 1 bend. And we chose a 18 millimeter device. We oversized the device by 4 millimeter. Defect was 14 millimeter. This is the LV angio showing a large ventricular septal defect with left to right shunt. It is apically located. We crossed the defect with a thermo glide wire from left to right, placed the glide wire in the pulmonary artery and snared from pulmonary artery, brought it out through the right internal jugular vein. This is the arteriovenous loop. Here you can see the catheter has come from the right femoral artery. It is the descending aorta to ascending aorta to left ventricle. from left to right ventricle crossed through the ventricular septal rupture, and the guide wire has been brought out through the right atrium, SVC, and right internal jugular vein. So once this AV loop was established, over this loop, 9 French delivery sheath was brought in by kissing catheter technique to prevent entanglement in the chordae and the tissue at the rupture site. We placed the delivery sheath in the left ventricle. We brought in the 18 millimeter device, deployed the left ventricular disc. We checked with the hand injection through the pigtail, positioned the device exactly at the rupture site, pulled it back gently but firmly. After confirming the position, we deployed and released the device. The device was stable. Initially, there was some residual shunt, but it gradually subsided over 10 minutes. And subsequently, patient recovered without any complication. His symptoms of heart failure improved. Echocardiography showed a well-placed device with minimal residual shunt, which disappeared pre-discharge. This is more than 1 year now after the procedure. He remains absolutely asymptomatic. He walks to the fields 2 kilometers away and back. This is the follow-up echo, where you can see the device well seated with normal LV function, no shunt across. A few points for discussion. Why to close, and what happens if we do nothing, a ventricular septal rupture? We'll see the natural history. When should we close the ventricular septal rupture? The timing. And how to close ventricular septal rupture, well, by surgical means or by percutaneous. Fortunately, ventricular septal rupture has become rare after advent of PAMI, less than 1%, but 25% of them die with cardiogenic shock within 24 hours. The prognosis is grim, and 90% of medically managed patients die within 2 months. Surgical repair in acute stage is difficult because of the friable margins. Most do not do well. And inferior MI ventricular septal rupture is complex, has got serpiginous tract, and has got higher mortality. The mortality in general remains high, and timing of repair has to be individualized. If a patient is unstable, he should be supported with mechanical circulatory devices like ECMO, tandem heart, LVAD, and then the definitive surgery should be delayed. Because if you operate early, surgically closed VSRs within 24 hours have a mortality of 60%. If you try to close by transcatheter technique, the mortality is up to 88%. On the other hand, if you stabilize the patient for about 3 to 4 weeks and then close the rupture, then the mortality is relatively less. However, there is always a selection and survivorship bias because more critically ill patients generally succumb in the acute stage, and those who are slightly better off survive up to 3 weeks. If you do not do anything, if you manage only medically, then the mortality is very high, up to the tune of 95%. So to conclude, ventricular septal rupture is rare but life-threatening complication. It has got dim prognosis. Complete revascularization should be done before attempting the closure. We have to individualize the timing and modality of closure. And one need not chase small residual shunts because they are hemodynamically insignificant and usually close over a period of time. Thank you for your attention.
Thank you, Dr. Keshava Morse. For this case, is there any question and comments? So, Dr. Keshava Morse, so I'd like to ask one thing. You found the ventricular septal defect at almost 2 months beyond 2 months, right?
Yeah, 2.5 months after the initial event. Yeah.
Okay, so do you think that occurred 2 months later or the earlier, or how do you think?
Absolutely. This is a very unusual timing. Generally, it has got a bimodal presentation. It happens generally early or within a few weeks. So 2.5 months later is a rare occurrence.
Okay. So
generally, it doesn't happen. Right. There are different types of ventricular septal rupture. In fact, Becker type 1, 2, and 3. The Becker type 1 happens in the acute stage where, it is a slit-like tear. Whereas the Becker type 2 happens subacutely. It is because of the erosion of the infarcted myocardium, because of the coagulation, necrosis, and neutrophilic infiltration and shear stress. Whereas the Becker type 3 occurs very late due to the perforation of the aneurysmal part of the myocardium, thinned out and aneurysmal. So the different types of ventricular septal rupture occur at different timeline.
Okay, so another question is, did you perform the transesophageal echocardiogram? Because for the accuracy of the size of the ventricular septal defect, the transthoracic echo might be not enough, I think. So did you perform the transesophageal echocardiogram as well?
No, sir. No, we did not perform. Here, the ventricular septal defect was located little in the apical side of the interventricular septum, and it was clearly visible on the transthoracic echo. So if there was any doubt of the margins or the size, then we would have done the transesophageal echo. So we did not perform the transesophageal echo.
Okay, thank you.
Thank you, sir.
Dr. Murthy, congratulations for this educational case. As you say, it's a little bit infrequent to see late ventricular septal ruptures, and most of them occur in the acute phase. And it's really a problem to just use devices, and also for the surgeons because of the friable margins. And sometimes we use these unplugged devices, but we are not sure that we have to use another unplugged devices after, because sometimes you can find a residual shunt that you have to close again. I want to ask you, you use a special septal device? This unplugged was for septal rupture, or was the normal septal device that you use in this case?
Sir, we used the normal muscular Amplatzer septal device. We did not use the post-infarct device. In fact, ideally, post-infarct device should be used if it is available, because it has got the wider discs and longer waist. Whereas the normal muscular device has got a waist length of 7 millimeter, and the discs are 8 millimeter larger. So we used 18 millimeter device. So its disc, LV disc was 26 millimeter. If we had used the post-infarct device, the special device, then the waist length would have been 10 millimeter, and the LV disc would have been little larger, up to 28 millimeter. So that would have been the ideal one. But since we didn't have the ideal the device, we used the muscular device.
Okay, thank you so much.
Thank you, sir.
Dr. Seung-Ho, I think we have to move to the next case.
Okay, so let's move on to the next speaker, Dr. Hong Seng-Lo from Malaysia. His title is The Big and the Stubborn, the Persistent Intracoronary Thrombus. Dr. Hong Seng-Lo, please.
Okay, good evening, everyone. It's good to meet up with all of you today to present my case. The title is Big and Stubborn, regarding a persistent intracoronary thrombus. Okay, I have no potential conflicts of interest. We have a 56-year-old male with 40 pack years of smoking and dyslipidemia. He presented to a district hospital about 6 hours after onset of angina. He was hemodynamically stable. The ECG showed sinus rhythm with ST elevation in inferior leads, suggestive of inferior ST elevation myocardial infarction. However, there were no cardiac catheterization facility nearby, and hence he was given oral aspirin with clopidogrel, and he was successfully thrombolized with the IV streptokinase, and he was then continued on dual antiplatelet therapy with subcutaneous low molecular weight heparin while waiting to be transferred to a cardiac center for early coronary angiogram. The repeat ECG at the cardiac center shows sinus rhythm and the ST elevation resolved, and there was persistent T inversions in the inferior leads. The echo shows left ventricular ejection fraction of 50% with inferior and posterior wall hypokinesia. This is the first coronary angiogram performed, which is about 1 week after the onset of myocardial infarction. The normal left coronaries showed that circs are normal, and the left LAD is also normal, with some collaterals to the distal right coronary artery. However, the angiogram of the right coronary artery shows a complete occlusion from the proximal RCA with high thrombus burden, with TIMI thrombus grade 5. This is a diagrammatic representation of a general approach to intracoronary thrombus, which is divided into two therapeutic arms. First is to prevent thrombus propagation or to prevent new thrombus formation. And the second is to restore coronary flow. So to prevent thrombus formation and also propagation, generally we give anticoagulation and antiplatelets. And to restore coronary flow, basically we, if there is ongoing ischemia, we will try to remove the thrombus by various means. However, if there's no ongoing ischemia, we can consider giving antithrombotic therapy and repeat the angiogram later. So we attempted to do a thrombus aspiration during the first coronary angiogram because the patient was already on antiplatelet, dual antiplatelet and anticoagulation for a week. So the wire crossed the thrombus easily, and we tried to aspirate the thrombus. There were a lot of thrombus being aspirated. However, despite multiple attempts, we can still see there are a lot of thrombus still in the RCA, and we are able to establish some blood flow, which is about TIMI 2. So because of the persistent high thrombus burden, we decided perhaps we should to give anticoagulation, antiplatelet further. So we gave IV glycoprotein 2B3A, which is tirofiban in this case, and it was given for 36 hours. And we also continued on the subcutaneous low molecular heparin, which is fondaparinux in this case, for 5 days. Fortunately, he remained stable without any angina during the 5 days, and we decided to repeat the angiogram 5 days later. This is the second coronary angiogram. Again, we can see there's a persistent heavy thrombus burden in the RCA despite already 12 days of antiplatelet and anticoagulation, and the TIMI, the flow is only TIMI 1. So we attempted again a thrombus aspiration with the export advanced catheter. Again, we failed to remove most of the thrombus. And most likely the thrombus are already well organized. They are pretty hard to be aspirated. So what do we do next? In this case, we have attempted thrombus aspiration in two different angioplasty, but we still fail to achieve satisfactory result for either intracoronary imaging or even for stenting. Because if we were to decide to stent now with so much thrombus in there, we may have a risk of acute stent thrombosis or even undersized stent. So we decided perhaps we might need to perform a mechanical thrombectomy device, but unfortunately the device was broken that day and we couldn't use it. So we have to decide an alternative management for this case. So we had a long discussion with the patient and also with various teammates. We decided that perhaps we should consider a longer duration of antithrombotic therapy before we repeat another angiogram. So this patient also had a very low bleeding risk score, and therefore it is relatively safe for us to consider starting him on a dual antiplatelet therapy with direct oral anticoagulation, which is rivaroxaban in this case. And the dose was 20 milligram daily for 1 month. Just for the knowledge, there is no guideline regarding this therapy for such a case till date. He was also not keen for oral vitamin K antagonist or subcutaneous low molecular heparin because the patient will need to repeat his INR frequently, and also he has to stay in the hospital to continue on the injections. So he decided to be discharged first, continue on the dual antiplatelet therapy and also the rivaroxaban for 1 month. So after 1 month, we brought him back, and as you can see, the result is quite amazing. All the thrombus are already gone. We have pretty smooth vessel. However, there's some moderate disease in the mid RCA. For the record, we did a FFR, and the FFR shows it was a 0.98. Therefore, we decided stenting was not required at this time. So he was actually discharged well on the same day with the dual antiplatelet, plus the standard guideline-directed medical therapy, and he has been well for his first year of follow-up. So for the conclusion, this case actually discuss about a persistent and extensive as well as organized intracoronary thrombus in a patient with a recent inferior STEMI, despite given IV streptokinase, multiple antithrombotic agents, and also multiple attempts of thrombus aspiration. Further intracoronary intervention was delayed, allowing for a longer duration of antithrombotic therapy with DAPT and direct oral anticoagulant till 1 month, which actually resulted in a complete resolution of the intracoronary thrombus. And also, in this case, it also prevented unnecessary stenting of the vessel without any significant stenosis. And therefore, this case actually describes that sometimes by doing less, we are actually able to achieve more. So this is in contrary to the previous cases that are being presented by other participants, which involve a lot of highly technical procedures. But however, in this case, we only prolong the medical therapy, avoid any complicated or complex procedures, and hence we are still able to achieve a good result. But we still need further trials or evidence before we recommend this for all cases of all similar cases of such. Yeah, thank you for your attention.
Okay, Dr. Low, very educational case. Thank you very much, and congratulations of your successful the case. So, is there any questions and comments?
I think it's a very nice and excellent case, but it is some concern because after 5 days of initial index coronary angiography, the flow was TIMI 1. Yes. So if the culprit lesion was culprit lesion, if culprit lesion is LAD or another suck or left main, this is a strategy would be more dangerous. So we should concern about that. Yes.
Yeah. Thank you, Dr. Seung-Ho, for this educational case. We understand that this is an off-label indication of DOACs. Right. And yeah, there is some considerations about this case. When you do aspiration with the export catheter, you can also embolize. So this has been shown in some of the trials, and we have to be aware that many of these aspirations are could be harmful and may end with a stroke. So the recommendation for this case as was just done by the other panelists, maybe was to stent this case just in the minutes when you have only TIMI1 flow and see what happened with that artery and not left only by DOAC treatment. Maybe this isn't a successful case, but maybe it's also anecdotal. That's my comment. Yeah. Okay. Thank you very much.
Dr. Rowe, how about in this case, in long term, how do you think your management for these patients?
Well, the patient, he has a background of smoking and also high cholesterol level. So I think the most important is to advise him to quit smoking and make sure that his cholesterol is really under control. And of course, we will closely monitor him because he has got still got some moderate disease in the mid-RCA, and there's a possibility that it may progress in the future. So if he has any sign of ischemia or having any ACS, then perhaps we may consider to stent the lesion. Yeah. The reason why we didn't balloon and stent in the beginning was because at that moment when we first did the angiogram, the patient no longer had any more angina. There was no evidence, sign of ischemia by then. So we thought we would have to take some time to give the medical therapy before we decide whether we should stand or not. And further, there was so much thrombus, we were not confident that whether when we do any intracoronary imaging, or perhaps we may have actually underestimated the size of the RCA, and we might actually put a smaller stent, and that will be a high risk of acute stent thrombosis.
Okay, thank you. So for the timing, let's move on to the next speaker. The next speaker is Dr. Sridhar Kasturi from the India. His title is Peripheral Angioplasty for Gangrenous Left Ring Finger with Septicaemia. Dr. Kasturi, please.
Good evening to all of you. I hope my slides are visible. I have no financial disclosure or conflicts of interest. But this is a 60-year-old male, non-diabetic, hypertensive, presented with a history of fever associated with chills and rigors. He had a gangrenous changes and claudication of the left forearm. He underwent PCF LAD in 2011 and failed attempts of PCF RCA. Attempted twice, but finally it was they did successful PCA. ECG normal, Todiaco no RWMA, good LV function. Investigation showed leukocytosis, and right hand blood culture showed serratia. CT iodogram we did that showed the forearm angiography, diminished flow. There is no flow of radial, ulnar, and palmar arch. This is the CT image. You can see very clearly. We are unable to see the radial artery, ulnar artery, and palmar, like a deep palmar arch, superficial from distal arteries. So our plan is, because he had a gangrenous ring finger, left ring finger with cellulitis and fever, episodes of chills and rigors, our intention was to establish the blood flow to the hand so that they improve the flow and you just control the infection. The indication was like limb-threatening ischemia. We have chosen the right femoral approach because the antegrade approach through the brachial approach may hamper the blood flow further. So that's the reason we avoided the brachial. So the angiogram, we used JR catheter from the right femoral approach. Unable to see any flow in the radial, ulnar, and palmar arch. You can see very nicely. If you see, our intention is to open the superficial palmar arch, even digital arteries, we have to do the balloon angioplasty, open the right radial, left radial, and left ulnar artery. This is our plan. So we have taken the JR guiding catheter and turbo wire, and it was placed in the brachial artery. And we took the fielder FC 014 wire using the fine cross. Then we crossed the ulnar artery, and it was dilated with 2 into 120 mm peripheral balloon. And this is the balloon dilatation. Then distally, we took the Tajuna 2 and 2.5 mm balloon, distal portion of the radial artery, ulnar artery, as well as the distal artery was done. The post balloon, we are unable to see any flow. Still, then we did one more dilatation, placing the fielder FC into the distal arteries, and with microcatheter support, you can see the wire is placed in distal arteries, and we carried multiple dilatations. You see the distal ulnar artery again dilated 2 into 80 mm peripheral balloon, and including the distal artery, we dilated all the distal branches from the palmar arch. And microcatheter injection, you can see the flow is established, and then you can see the arch, you can see palmar arch, you can see distal arteries, you can see, but subsequently developed slow flow. Then again redilated with 3 into 120 mm balloon, then dilatations. Then we have retrogradely entered the radial artery through the through palmar arch. Then palmar arch as well as the radial artery was dilated with 3 into 120 mm PTA balloon. You can see the balloon dilatation. Then again distal arteries are open, palmar arch Then antegradely, again, we enter the radial artery using the fielder XT. So one wire from the radial artery, one wire from the ulnar artery, palmar arch, entering into the radial artery. Then again, slow flow notice. Then we gave intraarterial Nicoran and nitroglycerin injections. Then again, antegrade placement. Then again, it was dilated, radial artery was dilated 2.5 into 50 mm Tajuna balloon up to 10 atmosphere. Palmar arch and the radial artery was dilated with 2.5 into 120 mm balloon. So we have dilated ulnar, radial and distal arteries as well as the palmar arch vessels. So brachial artery contrast injection after 200 micrograms of nitroglycerin, TMG Nicoran. Then you can see the, again, it was redilated again. So multiple dilatation. Subsequently, then we took the injection. Then you can see nicely filling palmar arch, ulnar artery, radial artery, including the distal branches. You can see the distal branches also you are able to see. So there are only few case reports are available. There is one series that is angioplasty of the below the elbow arteries for critical limb hand ischemia. This is more oftenly observed in patients who are suffering from renal failure. So here in this series, they found very clearly the mortality rate is low and even the MACE rate is very low. And they have shown successful results with the healing of limb ischemia, relief of limb ischemia. There are few reported cases. Here, the patient developed gangrene of the third to fifth fingers and proximal radiated occlusion, where they did the 2.5 to 120 mm balloon dilatation. They have put stents also. This is the only one case report I saw that stents were implanted, but it would be preferable to avoid the stents because the superficial and compression, it can muscular compression, it can, the stents get distorted. Ideal to do the balloon dilatations. If needed, you can do the drug-eluting balloon also. And one more report, the distal radial artery, and they did the angioplasty balloon. They used 2 mm balloon. And all these cases showed very good patency of the radial and ulnar artery. And only one case was, they have reported, including the palmar arch, everything dilated. But our case unique in this one, we did the ulnar, radial, and even deep palmar arch, as well as the superficial palmar arch, as well as the distal arteries were open, and then with successful results. This is a follow-up CT angiogram. You can see very nicely. This is very well patent, though we are unable to see the ulnar, radial artery, and you can see the superficial, deep palmar arch, as well as the distal arteries. You can see very, very clearly well seen. So this is the follow-up. We took because the ring finger, the distal portion was gangrenous. The last digit was amputated. You can see 1 month later, he's totally relieved of fever. The sepsis subsided and recovered remarkably without any claudication. Now he's absolutely. This case was done about 1 year ago. Even today, he's doing very well without any problems. So balloon angioplasty forearm vessels is very much possible and feasible, where the clinical situation demands mainly due to occlusion of like radial or ulnar or even arch vessels leading to life-threatening ischemic conditions. Procedure can be performed through antegrade brachial approach or through the femoral approach. Antegrade brachial approach purposefully we have avoided here because it may hamper the flow further, and it may cause some dissection is there. So that's the reason we went ahead with the femoral approach. There is no supportive data for usage of stents and DEB due to limited experience and limited published case reports. Very few cases are reported, and it's very difficult to, but rationale wise, you can use the drug-eluting balloon instead of drug-eluting stents, which can work well. Adjunctive pharmacotherapy should be recommended for better acute and long-term results. That is very, very important. And see if the atheroma is there and adequate antiplatelets. These are all very, very important. Suppose if the patient is having atrial fibrillation, thrombus is there, adequate anticoagulation to prevent such type of events are very, very important. If the hypertension control of the risk factors are very, very useful in maintaining the long-term patency of these vessels. Thank you, one and all, for paying me this, for paying attention.
Okay, thank you, Dr. Kasturi, for your night case. Is there any questions or comments from panelists?
Okay, hi. Thank you for your excellent case, Dr. Kasturi. One comment. So in this case, in this patient, the no-flow or slow flow phenomenon caused by the microemboli, so the distal embolization. So sometimes using the over the wire balloon and occluded the proximal site, and once the guide wire pulling out, and the drug infusion from the over the wire lumen from the occluded balloon. So the high pressure infusion of the sometimes some kinds of the diuretic agent, so nitroprusside, or so we sometimes use papaverine. So maybe 3 or 4 or 5 times repeated. So sometimes the blood flow is improving. So in my experience.
That will be useful for if the acute occlusion is there. This is a chronic condition with the inflammatory occlusion. It's organized. And despite using balloon dilatations, we are unable to maintain the patency because it required almost multiple dilatations. So if the acute thrombotic occlusion or some vasospasm is there, you go distally, put the microcatheter, remove the wire, and distally you can give the nitroprusside or even any papaverine, all those drugs you can try. But I think in this case, because even the small distal arteries are closed, the reconstruction of the entire palmar arch and distal arteries is the only way. And subsequently, if the flow is restricted or the vasospasm is there, that time you can maintain these drugs. But this is not because of the thromboembolic phenomena. This is because the reason is unknown, but mainly he has a chronic atheroma because previously he underwent desk implantation and subsequently he underwent repeat angioplasty for right coronary 2 times. 2 operators struggled for 2-3 hours. They were unsuccessful. And finally we could cross and we performed the right coronary. That means he has an aggressive atheroma, maybe because the atherosclerosis, though, which is unusual in the forearm vessels without involving the other vessels. But the LV function is absolutely normal. No rhythm disturbances to explain thromboembolic cause at atheroma. Maybe because the atheroma unusual site could be the reason for it.
Thank you.
Thank you, Dr. Kasturi, for this, for sharing this interesting case. And this could be also a way to go for some of the complications when we use radial and ulnar arteries. And most of them, when they get thrombosis, these patients are asymptomatic. But anyway, I was thinking we can rescue many of these cases and making this technique very useful. And I want to ask you, why did you choose so long balloons for this case? Is there a recommendation, or why did
for any peripheral interventions, we use long peripheral balloons because long balloons, because diffuse long segment lesions. Because sometimes what happens if you take a small balloon, you have to give multiple balloon dials. That times the block may shift here and there. Ideal to take the longer balloons for all early. Below knee also we use like a 200 mm, 120 mm, 150 mm balloons so that the atheroma gets compressed. So peripheral angioplasty requires like a 120 mm, 150, 200, depending on the segment. You can, at a time, you can do balloon dilatation. The flow time will be saved and the maximum lesion can be covered in 1 or 2 sittings.
Okay, thank you so much.
Okay, thank you. For the time limitation, let's move on to the next last speaker.
Thank you.
Dr. Sapisankar from the Indonesia. His title is Spontaneous Coronary Artery Dissection Complicating the STEMI in Young Woman, to stent or not to stent. Dr. Seung-Ho, please.
Thank you. Hello, everyone. It's my honor to speak here. Today, I would like to share our case, spontaneous coronary artery dissection complicating ST elevation myocardial infarction, to stent or not to stent. I have nothing to disclose. And here my case presentation, a female 36 years old with the diagnosis recent stemma anterior. From the clinical presentation, the patient complained chest pain and performing fibrinolytic at local hospital and then referred to our hospital for further management. She had no history of traditional atherosclerotic risk factor and had history of preeclampsia previously. Her physical examination and laboratory findings were normal. Here, the ECG showed is the elevation with biphasic T wave at anterior precordial lead. We performing echo with, we found the hypokinetic at anterior segment with the ejection fraction 52%. And then we perform coronary angiography. We can see here the RCA was normal, and left coronary angiography showed contrast staining at proximal to mid part of LAD with distal compromised flow. From the caudal view, we can see here the double lumen appearance maybe indicates some of dissection. So what is the next plan? Actually, we decided to manage conservatively at the initial. However, this patient still complaining chest pain, so we proceed to perform a PCI at LAD. And here, the 1 month later, we can see the coronary angiography show the progression of the disease, totally occluded from mid to distal part of LAD. And then we use floppy wire 7 blue with support microcatheter fine cross to cross the LAD, and we advance the wire carefully. And here the critical point, we have to ensure that the wire is on the distal true lumen. So we make a distal tip injection from microcatheter. We can see the contrast field on the LAD. And we continue to multiple pre-dilatation with a semi-compliance balloon. And then we use OCT to evaluate the mechanism of dissection and guided the next management strategy. From the OCT, we can see here the dissection at proximal part of LAD, and with we found the large intramural hematome with we measure the size 2.5 or 30 millimeter. And we continue to pre-dilatation with NC score flag balloon to fenestrate the intimal and allowing the compression of the intramural hematome. And then we put the long stand dash 3.0 38 millimeter, and we deploy 16 atmosphere. And this is the final result. We can appreciate here that the intramural hematome still present. However, the flow to distal LAD has improved. And we perform the OCT post-stenting. We found a well-opposed and well-expanded stent at proximal mid to distal part of stent, and no dissection, and intramural hematome covered, fully covered by stent. And we evaluate this patient 1 month later. From the coronary angiography, we can see here, we can appreciate here the intramural hematome completely healing with a good distal flow, and stent placed well, no leg complications in angiographically. For the discussion, SCAD is non-iatrogenic, non-atherosclerotic coronary artery dissection, resulting in the formation of an intramural hematome or false lumen in the coronary arterial wall. The true prevalence remains unknown. However, some study reporting that the prevalence between 1 to 4% of all HAS cases, with the higher in the young to middle-aged woman, especially below 15 years. And there are some conditions that can cause a triggering or contributing for developing of SCAD. Some of emotional stress, medication may be related with hormonal or intense exercise. And SCAD classify into 3 types, where the type 1 represent the radiolucent flap and linear double lumen, and type 2 indicate the long lesion diffuse, and type 3 focal lesion or focal stenosis. And here the suggested algorithm management of SCAD proposed by Dr. Seung. When we faces the patient with SCAD and clinical high-risk features such as ischemia, cardiogenic shock, and sustained ventricular arrhythmia, revascularization should be considered, whereas the PCI preferably if indicated if feasible. The operator need to confirm that the coronary wire is on the distal true lumen before we proceeding to perform the angioplasty or stenting. And we can use the guide from intracoronary imaging such as OCT or IFUS to confirm the position of the wire. Once the vessel is successfully wired, there are many different technical options for angioplasty and or stenting. For the conclusion, the diagnosis and management of SCAD remains challenging. The recent development in angiographic characteristic and intravascular imaging have revolutionized our understanding of SCAD. Awareness of its high prevalence, especially in the middle-aged woman presenting with HAS in combination with the diagnostic workflow algorithm, will aid to deliver an individualized treatment. And OCT provides detailed visualization compared with other imaging modalities and may increase the diagnostic yield as well as guided treatment strategy. Okay, thank you.
Thank you for your nice case, very educational and a good result. But this patient is a very young woman.
Yeah.
So from the long stand, in the future might be some concern, but I know that situation is inevitable. So my question is, once you found medial dissection by OCT, how do you think spot stenting or long stenting? Okay. How do you think?
Yeah, okay. I think we found the dissection is detection from the OCT. From OCT, we can see the medial dissection. So we decided to put the long stent in order to prevent if we use the spot stenting, we're afraid to propagate or maybe make some extension of the dissection. So we put the long stent to fully cover the intramural hematome. Mm-hmm. However, yes, what you said before, it's maybe cause some problem. We should evaluate in the next time.
Yeah, because sometimes that propagation is not usually always occurred from the distally. Sometimes the proximally also the propagation makes some problem, case.
Thank you for your excellent presentation. I have a question. Maybe OCT procedure is increase the dissection site. Why do you select choice OCT procedure in this patient?
Okay, thank you for your question. We use the OCT. Actually, we want to make a better or detailed visualization. As we know that the OCT has a better resolution, and we can see the clear mechanism of the dissection. However, there is some limitation. Maybe we should be careful about the contrast injection when we perform the OCT. So it will make more propagation of dissection.
Am I a comment?
Yes, sure.
Okay.
Actually, the OCT should not be used when acute ongoing pain is there, hemodynamically unstable situation, or patients who have a cardiogenic shock, or if you are distally, it's not open. So only proximal tear is there still spreading. That time, if you do OCT, it can spread. But if you have a intermedial block, proximally and distally, hemodynamically stable, no ongoing pain, that time, the well-stabilized patient, that time you can do, because the high resolution image, you can see very clearly true and false lumen. You can see the landing zones, pay to land. Here, there is no need to take the total length. Only proximally you can see where the intimal tear, you can see the diagnosis. But acute situation, IVAS is preferable, but stable hemodynamically, the OCT. There are certain guidelines when to use the OCT, when to use the IVAS, particularly spontaneous coronary artery dissection. Thank you.
Okay, thank you for your comment. Okay, so I think we will have the close time. Okay, so the chairman, Dr. Francisco Riquelme, could you
Yes.
comment the closer remark? Please?
Yes, well, thank you all for this excellent session. I think all learned a lot. And I want to thank the presentations, also my co-chair, Dr. Seung-Ho, and all the contributions of our distinguished panelists. I want to thank also the scientific committee and the CBRF, and I wish all of you an outstanding and successful 26th TCTAP Virtual 2021. And for sure, we look forward to see you soon, and please take all of you care, because we haven't resolved this pandemic issue yet. Thank you very much.
Okay, thank you. Thank you for the participation, all the presenter and the discussant. Okay, so bye-bye.
Bye-bye.
Yeah, thank you.
Thank you.
Thank you all.